Very good morning to everyone. My patient, a 66-year-old lady, married and a homemaker, a Hindu by religion and a resident of Gurgaon, presented to us with chief complaints of abdominal distension for the last 3 weeks and dull aching pain in the lower abdomen for the last 10 days. She was apparently asymptomatic about 3 weeks back when she observed abdominal distension, which was insidious in onset and gradually progressive to attain the present status. It was associated with dull aching pain in the lower abdomen, which was more significant for the last 10 days. It was again insidious in onset, intermittent, and it was relieved on taking oral medications. There were no aggravating factors for the pain. The distension was not associated with any nausea or vomiting. There are no history of any altered bladder habits in the form of increased frequency of micturition. There is no history of altered bowel habits like constipation or increased frequency. There is no history of fever or any pervaginal discharge. There is no history of any pervaginal bleeding. She does not give any history of weight loss or loss of appetite. There is no history of cough, chest pain or hemoptysis or any other history suggestive of metastasis. Coming to the past history, she does not give any significant medical history. There is no known history of diabetes, hypertension or tuberculosis. There is no history of any previous surgery as well, and there is no history of tubal ligation. In the obstetric and menstrual history, she was married at 22 years of age. She is para 2 live 2, and both the children were born by normal spontaneous vaginal delivery. The first child was born at 23 years of age, and the child was exclusively breastfed. There is no history of OCP usage. She attained menopause at 50 years of age. Personal history. She consumes a vegetarian diet. Her bowel and bladder habits are normal, and there is no history of any addiction to alcohol or tobacco. In the family history, there is no history of similar illness in any first or second degree relative. There is no history of breast, ovarian, colorectal, endometrial or any other malignancy in any family member. History. A 66-year-old postmenopausal lady, para 2 live 2, with complaints of gradually progressive abdominal distension for the last 3 weeks, associated with history of dull aching intermittent pain in the lower abdomen for the last 10 days.
So Vartika, can you just discuss some salient points of the history while you're here? Can you go back to your first or second slide, please? Yeah, come to your negative history. Yes, that's right. So now you should know what negative history you're asking and why you're asking all that negative history. Okay. So obviously, what is the reason? Okay. So what is the reason you're asking for negative history? What are you trying to eliminate? First, let me ask you that.
Ma'am, since she's a 60-year-old female, relatively old age, so I want to rule out malignant causes. From that perspective, I have tried to rule out GI causes and genital causes. So in GI causes, I wanted to rule out involvement of bowel. She does not have any altered bowel habits, and it can be a genital cause like an ovarian mass or a uterine mass. So she does not also give history of any pervaginal discharge or any fever which may be associated with pelvic inflammatory diseases. Yes, ma'am, these are the causes I wanted to know.
So when we take a negative history, we are trying to determine what would be the differential, number one. Number two, if we are leaning towards a diagnosis, we would like to know how far the disease has gotten along. Okay. So here, like you rightly said, the negative history should include, history to rule out any bowel disease. And also, Because 85% of, if you are even thinking of an ovarian malignancy, we know beforehand we are presenting a case of ovarian malignancy. But if a case like this comes in hand, you always have to rule out GI causes, because even in ovarian malignancies, 15% cases can be metastatic. So like you rightly said, there is no alteration in bowel habits. So bowel habits not only increased frequency and constipation, you should be only asking history of any bleeding per rectum, any nausea, vomiting is okay, any history of early satiety habits. Now for a 60-year-old lady, the chances of pelvic inflammatory disease will be quite less. We expect it more in a younger woman. So this will be lower down the list, okay? So if a patient is presenting with an abdominal discharge, yes, you can ask history of postmenopausal bleeding. Reason being that some tumors of the ovary do present with postmenopausal bleeding. In order to rule out any uterine mass, yes, that can be a part of your differential diagnosis, definitely. Changes in bowel, bladder habits, increased frequency, incomplete evacuation, all these should be asked. Weight loss, loss of appetite is good. Why have you asked history of any cough, chest pain or hemoptysis?
Ma'am, to rule out distant metastasis to the lung and
Yeah, so distant metastasis to the lung, especially with this kind of a picture that would pertain to parenchymal mass, is actually rare. Here we are trying to rule out a patient who's presenting with abdominal distension progressively increasing. In India, a very common cause is abdominal pelvic coughs. Okay, so it can happen even in this age group. So that is the main reason why we're asking this. So any history of fever, any history of weight loss, any history of night sweats. Okay, all this is more important to rule out abdominal tuberculosis. The chances of parenchymal lung mets in a case of PA ovary presenting with 3 weeks history is generally less. Like I said, the differential of PID is relatively lower down the list. So yes, you have to ask for bowel habits. That should include constipation, increased frequency, bleeding per rectum, nausea, vomiting, early satiety, change in bladder habits, increased frequency, sense of incomplete evacuation, any history of fever, weight loss, loss of appetite, cough, chest pain, any history of postmenopausal bleeding. What else? What else can present as an ovarian lump besides this thing? Besides GI malignancy, what else can present with an ovarian lump? If you're thinking in terms of malignancy, rarely a breast cancer can also present. So for any history of feeling of any lump in the breast or anywhere else in the body.
breast malignancies and colonic malignancies can lead to.
Yeah. So you've already asked for bowel habits. Do ask for any history of any lump in the breast if a woman has felt so herself. Okay. So can you just go up on the go down on your slide? Sorry, next slide. Yes, this is fine. So why have you asked for history of tubal ligation?
Ma'am, in ovarian malignancies, it has been seen that tubal ligation reduces the risk of ovarian malignancies.
Why? What is the reason?
Ma'am, one reason is that it leads to a reduced blood supply, reduced vascularity, and another hypothesis is that it leads to reduced transmission of carcinogens via the fallopian tube.
Yeah. Okay. Next slide. Next slide. Yeah. Can you tell me what is the significance of a detailed obstetric and menstrual history in this woman?
Ma'am, patients who have high parity, they have a lower risk of ovarian malignancy per se. And then patients who have prolonged lactation or incomplete pregnancies also, these patients also tend to have lower risk of ovarian malignancies. And OCPs also have been seen to be protective for these malignancies.
When presenting a case, I think we should tell the risk factors first and the protective factors after that. So the risk factors is early menarche, late menopause. So here, if you know the age of menarche, that should also be mentioned. Okay. Then parity, not having nulliparity is a risk factor. Parity, like you mentioned correctly, okay, so that is a protective factor. Breastfeeding is a protective factor. What about OCP? How has it shown to decrease the incidence of ovarian cancer? You said it's a protective factor.
Ma'am, in females who have used OCPs for more than 5 years, the risk has been seen to be reduced by 50%.
What is the reason why? Stories of
Ma'am, it's
ovarian cancer is incessant ovulation. So the more the ovary ovulates, more there is the disruption of surface epithelium, which can have certain precancerous changes and then lead to cancer. One of the factors by which ovarian cancer is reduced by OCT is by prevention of ovulation. So there are different histologies of ovarian cancer. Okay, so which epithelial cancer is not protected by OCT? We don't see this, which is notch is a subtype which is not protected by OCTs.
ma'am, non-serous histology.
No, not all non-serous.
Mucinous.
It does have a protective effect on endometrioid. Correct, mucinous. That's right, mucinous. Because the histology is different, the origin is different. Okay. Next slide, please. Okay, yeah, next slide. Yeah. So why have you asked this family history?
Ma'am, I wanted to rule out any other malignancy in the same patient or in any other family member, such as breast and ovarian malignancies, which are a part of BRCA syndrome, BRCA mutation.
That's not called BRCA syndrome. What is it called? So what are you suspecting in these cases? In case you're asking for a family history, what are the syndromes you're suspecting? It's not called BRCA syndrome.
Hereditary breast and ovarian cancer syndrome.
Correct. It's hereditary breast and ovarian cancer. What else?
And Lynch syndrome.
Correct. So can you tell us a little bit about hereditary breast ovarian cancer syndromes? What are the genes involved? How do they present? Very briefly.
Yes, ma'am. There can be BRCA1, BRCA2 mutation, and apart from that, there can be BRIP1, RAD51C and D mutations as well.
Genes. Correct. Yeah. Okay. So what are these? So what is the dominant pattern? Is it a recessive pattern? What types of the genes are these? These are onco genes or these are tumor suppressor genes? Okay. So you need to read this. This is important not only for your Viva, but I think later on also they will be asking you. So it is an autosomal dominant pattern of inheritance. BRCA1 and BRCA2 are basically tumor suppressor genes. They are present on chromosomes 17 and 13, and their role is to suppress. So these are tumor suppressor genes. They are responsible for what? What are they responsible for? Which type of DNA repair? I'm giving you a hint.
Homologous recombinant.
Correct. So it is homologous recombination is involved in repair of double-stranded DNA breaks. So where there is a mutation of BRCA1 and BRCA2, there is a mutation, there is an erroneous DNA replication which leads to these tumors. So what is the difference between BRCA1 and BRCA2?
Ma'am, in BRCA1, there is the incidence of ovarian malignancies is higher, whereas in BRCA2, the incidence is lower, and they are also the incidence of hormone receptor positive tumors is more in BRCA2 mutation.
Yes. So the average incidence of BRCA1, the ovarian cancers is how much? It's about 40 to 55%, and it's about 11 to 20% in BRCA2. Is there an age difference of presentation as well?
Yes, ma'am. BRCA1 presents at a lower age group. BRCA2 around 30 to 40 years, BRCA1, and BRCA2 at around 40 to 50 years.
Yeah, so BRCA1 is around 35 to 40 years and BRCA2 is 40 to 45 years. Does it impact your management of these patients?
Yes, ma'am.
Does this knowledge impact your management of these patients?
Yes, ma'am. In patients with, if we have to plan for risk reduction surgeries, we can plan for a later age in BRCA2 patients.
Correct, absolutely. So with the risk reduction, what is the risk reduction surgery called? What do you do in such patients?
Risk reduction.
Yes.
Risk reduction correct.
Correct. So what is the incidence of reduction of ovarian cancers in these, with these type of surgeries?
Ma'am, if ma'am, it's around 60 to 70%.
No, it's at least 85%, 85 to 90%. If you consider all the cohorts, okay. So it has a very high risk of reducing ovarian cancers However, there is still a chance of primary peritoneal cancer even after you do an RRSO, up to 4%. Does it also reduce the incidence of breast cancers?
Yes, ma'am. It reduces the risk of breast cancer by 30 to 40%.
Yeah, 40 to 50%. Correct. Okay. So, so this is basically what the family history is. And generally, these type of, what is the incidence? If we consider 100 cases of epithelial ovarian cancers, how much percentage would you allocate to patients with familial breast ovarian cancer?
Ma'am, up to 10% patients.
15%. 15%, yeah, 15%. And they generally occur about a decade earlier than the average age of presentation, which is, what is the average age of presentation of ovarian cancer?
Ma'am, 6 years, 60
yeah, 60
more
to
than
65 years. 60 to 65 years. The median is around 64. Correct. Okay. So, what is the other syndrome which you were talking about?
Ma'am, Lynch syndrome.
Correct. So, what are the genes involved in Lynch syndrome?
Ma'am, MSH2, MLH1,
What type of genes? What are these genes involved in?
Ma'am, these are tumor suppressor genes, ma'am.
So, and what is their function?
Ma'am, they tend to suppress the tumor cycle by suppressing
DNA mismatch repair. DNA mismatch repair. Okay, so they are responsible for DNA mismatch repair. So these genes which you are talking about, they are responsible for mismatch repair. And what other types of cancers are involved in this syndrome besides ovarian? What is the incidence of ovarian and what other cancers are involved?
Ma'am, the other cancers that can be involved are endometrial, colonic cancers, and gastric cancers, duodenal malignancies. Those have to be ruled out. And ovarian malignancy is about 5%.
About 10%. It's about 10%. That is why in these patients we do recommend removal of ovaries if we are doing a prophylactic surgery. So what is the incidence of endometrial and colorectal cancers in this syndrome? Roughly? Yeah.
Endometrial
50%.
is around...
it is around 50%. So 50% of the patients would present with endometrial cancer as the first. 50% may present with colorectal cancer as the first cancer. Okay. I think that's it. Next slide.
Just something.
Yeah. Please, Shweta, I was just.
No, you're going perfectly fine.
Just
in the previous slide, Vartika. So your family history, after you have taken 2 generations, actually, ideally, if you are mentioning 2, your examiner will ask that till what degree you have to inquire about the family history, and that has to be 3 generations, 3rd degree. Okay. So either you don't mention the degrees, or if you're mentioning, you mention that you have inquired till 3rd generation. Okay. It's good to mention that the patient doesn't remember about anyone having any type of cancer in the family, rather than mentioning 1 or 2 and then getting caught. Okay. Because 3rd generation तक तो पूछना भी मुश्किल है in a busy OPD, that everyone understands. And second thing is, you have to categorically mention that you have taken a family history both in the male and the female relatives. Like it is, you have to mention it. There is no history of such and such cancer in male and female relatives that the patient remembers of. Third thing, that this BSO, it actually gives a lot of protection to the extent of more than 95%. They say that around 2% cases of primary peritoneal can happen even after BSO. That is one thing. And one more thing, I was just okay. You can.
What's your summary again?
Summarizing my history, a 66-year-old menopausal lady, para 2 life 2, with complaints of gradually progressive abdominal distension for the last 3 weeks, associated with history of dull aching, intermittent pain in the lower abdomen for the last 10 days.
Yeah, that's fine. Shweta, do you have any more questions to ask?
Not here. She can move to
the Okay. Yeah, okay. All right.
On examination, patient was examined after explaining the procedure in a well-lit room with adequate exposure and after emptying the bladder. She is conscious, cooperative, well-oriented to time, place and person with a performance score of ECOG 1. Her weight is 55 kgs, height of 150 centimeters and BMI of 24.4 kilograms per meter square. She is afebrile, pulse of 64 beats per minute, regular rhythmic, normovolumic, blood pressure of 112 by 70 millimeters of mercury in right arm supine position, respiratory rate of 12 per minute. There's no pallor, icterus, cyanosis, or generalized lymphadenopathy. Coming to local examination of the abdomen. On inspection, the abdomen was distended more in the lower abdomen with a central and inverted umbilicus. The respective quadrants move equally with respiration. There is no visible dilated veins, pulsations or peristalsis. The hernial orifices were intact and external genitalia appear to be normal. On palpation, the inspectory findings were confirmed. There was no local rise of temperature or tenderness. A 25 into 20 centimeter mass is felt in the lower abdomen, reaching up to 2 centimeters below the xiphisternum, occupying the hypogastrium, the right and the left iliac regions, the umbilical region, and extending into the epigastric region. The superior margin was well palpable. The left and the right borders were also well palpable, but the lower border was not palpable. It has a smooth surface. It is firm in consistency, and it has restricted mobility. It is non-tender, and the liver and spleen could not be palpated. On percussion, there's dullness. There's dull note over the lump. There's no shifting dullness appreciated. Upper border of liver was palpable in the fifth intercostal space with a liver span of 12 centimeters. On auscultation, normal bowel sounds were heard. On genital examination, the external genitalia appear normal, no vaginal warts or excoriation. Urethral orifice appears normal. On first speculum examination, the vagina and cervix appear normal. On pervaginal examination, on bimanual palpation, the abdominal mass is palpable in the anterior and the right-left cornices, and there is restricted mobility. On digital rectal examination, the perianal skin appears to be normal. There are no piles, fissures, etc. The anal tone is normal. The rectal mucosa is mobile. Fecal staining is present. There's no blood tinging or fecal staining of finger was present. There were no nodules palpable in the pouch of Douglas, and the pelvic mass was palpable. On breast examination, the bilateral breast were no abnormality detected in bilateral breast and eczema. Systemic examination was essentially normal. Summarizing my history and examination, a 66-year-old postmenopausal lady, para 2 life 2, with complaints of gradually progressive abdominal distension associated with a history of dull aching intermittent pain in lower abdomen for the last 10 days and with examination findings of 25 into 20 centimeter abdominopelvic mass with smooth surface, firm consistency and restricted side-to-side mobility which was bimanually palpable.
So is that the end of your examination? Yeah. Okay. Can you go back to your first slide of physical examination? We'll start from there. So what are the ECOG statuses? Why have you said that this patient is ECOG 1?
Ma'am, the performance status of a patient is important to plan the further management of the patient. So if she's ECOG 0 or ECOG 1, we can plan for a surgical or a chemotherapy related management. But if she has a higher,
what I mean is, if you're telling an ECOG status and you're presenting this to the examiner, the examiner will ask you what are the ECOG scores. So 0, 1, 2, 3, 4, 5. You should know all this. What are the scores?
Yes.
What is
ECOG 0 means ECOG 1 is ma'am, ECOG 0 is when the patient is able to perform his daily activities and without any support from anyone, and he is able to do his daily activities on his own. ECOG 1 is when the patient is able to do his daily activities, but restricted daily work is hampered. In ECOG 2, the patient is mobile for more than 50% of the time of the day, and he is able to perform self activities also, but only to more extent that he is up and about more than 50% times of the day. ECOG 3 will be when he is restricted to bed for more than 50% times of 50% of the time of the day, and he's only able to perform a limited self activity. And ECOG 4 is patient is completely restricted to bed and is also not able to perform his self related activities. And ECOG 5 is patient is completely moribund.
ECOG 5 is dead.
ECOG 5 is dead, exactly. Shweta, I forgot what is the full form of ECOG? I think this was asked to us many times. Eastern something.
Bantika will tell.
European
Eastern. It's Eastern Cooperative Oncology.
Eastern Cooperative Oncology.
Yeah.
Interested in knowing that. Oh, yeah, I had forgotten it was some Eastern this thing, so you should know that. Okay.
Sorry, I joined a bit late actually. Just stuck with something. Sorry.
Hi, Anali. Hi.
Hello.
Good morning, sir.
One.
Okay, so
Continue, please.
yeah, okay, so no pallor, icterus, cyanosis. Okay. Does pallor and icterus have a bearing on this patient?
Pallor can be present in advanced ovarian malignancies, but if there is not is a rare
Pallor is
finding.
unlikely to be associated with advanced ovarian cancers unless you are expecting blood loss from somewhere. Okay. So why pallor is important is to rule out any GI. I mean, of course, iron deficiency anemia is one thing which is very common and can be related to any case. But besides that, if you're suspecting ovarian cancers, you are obviously ruling out metastatic cancers, which can be present in 15% cases. So wherever there is a source of GI bleed, which may be occult, okay, and it may not be presented in the clinical history, but the patient may present with pallor. So that is why pallor is important. And why icterus?
Icterus, it is rare to find in ovarian malignancies, but as a part of completion for general examination, I am asked.
No, so any liver occupying lesions are which may or may not be there. Intraparenchymal liver mets is common, is not so common. Yes, so they may present with icterus. Then it also tells you about what is the general condition of the patient. So if the patient, say, a case of advanced cancer were presented with ascites, and such a patient was coming up for surgery, all this will tell us about the performance status of the patient. If say you were planning to give her chemotherapy initially, medical oncologist would like to know whether the patient has jaundice or not.
Ma'am, adenopathy, it
Are you
indicates
only going to look at inguinal lymph nodes? What all lymph nodes will you examine in a case of CA ovary?
Ma'am,
Or any
axillary
abdominal mass
nodes.
for that matter.
Ma'am, axillary nodes to rule out any associated.
Either start from top to bottom or bottom to top.
Ma'am,
ऊपर से क्या
ma'am, left
देखोगे?
supraclavicular Virchow's node to rule out distant metastasis from GI malignancy.
Yeah. Axillary nodes.
Axillary nodes to rule out breast associated breast malignancies. Then inguinal nodes.
Axillary nodes may not necessarily be only involved in breast cancers. They may also be a part of spectrum of advanced ovarian cancers, which is presenting with lymphadenopathy. So sometimes we do get advanced ovarian cancer who have mediastinal and axillary lymph nodes on clinical presentation. So if a supraclavicular lymph node is positive, it's involved, what is the stage you allocate to the patient?
Ma'am, stage 4B.
Okay, and what about inguinal nodes?
Again, ma'am, 4B.
Yes, correct. Good. So, yeah, okay. So, next slide. Yeah. And I would suggest you do your systemic examination before you present your per abdominal findings. Okay. So,
yes, I was also going to say that.
Yes. So, it should follow a pattern. So, first, general physical examination, then your systemic examination, including your breast examination. And you should be mentioning your breast examination properly, that you could not feel any lumps, and nipples are, everted, there's no nipple discharge, and axilla are free, and then come on to the per abdominal examination. So, yeah, that is okay. Except that, when you mention the external genitalia, you say external genitalia are healthy. You don't say normal. You are not suspecting some hermaphroditism in this patient. External genitalia are expected to be normal, okay? This is a case where you are just saying that whether it is healthy or not. You expect it to be normal. Okay. So, yeah, next slide. This is okay. Inspection was fine. Yeah, so external genitalia are healthy. That is what is this thing. So vagina, cervix appear normal. So in a gynae examination, what we do is a PVR examination. Okay, so you can either mention PS, PV together, and then later on mention a PVR, or you can present them together as well. So here on a PV examination, I understand your DNB is in surgical oncology, but you should know some basics of a PV examination and what is to be mentioned. So Shweta, I think you'll be the best person. Tell
So,
what all should be included in a PV examination.
actually, first I was just going to mention about the per-abdominal examination, the inspection part. I will suggest that like you present the history like a PG student and not like a MBBS student. So your history should include everything which is positive, and whatever rest is there, like liver span is so much. So I don't know whether it is required in your surgical oncology
Fair
exam.
enough. Yeah.
But you
Correct.
can just mention no other organomegaly or hepatosplenomegaly. I mean, you have to be concise also when you are, because you are likely to make more mistakes if you mention more things. Just as like I'm not sure if you mention about the male orifices in the inspection part. Mention, I think it is in the palpation part, right? You mentioned in the palpation part, we evaluated the male orifices when we were doing the palpations. So if you mention more, you are likely to make silly mistakes on the exam, on which examiners can catch you. So it's better to be concise when you are mentioning, rather than to be so elaborated that you give them points where they can intervene unnecessarily rather than going to the last bit of it. Now coming to the genital examination. So genital examination, as mentioned, you have to mention whether healthy or any abnormality is found, or any abnormal discharge you are seeing, any bleeding which you are seeing coming from the orifice during your evaluation of external genitalia. Then PS examination, what you have mentioned is good only. That is what we report it as cervix and vagina normal, or if there is any abnormality, you have to mention accordingly. What abnormality can be discussed, that can be discussed in other cases where things are abnormal, like cervix or vaginal CS. Now coming to your pervaginal examination, you have to be somewhat like coherent when you are mentioning it. So you won't mention cervix at one point and go to adnexa, then again come to vaginal fornix, then again go to adnexa. Either you start from below, so you say cervix normal, fornix is normal, uterus size whatever it is normal, bulky, 6 weeks, 8 weeks, whatever you're mentioning. Are you feeling any adnexal masses? What is the size of the mass? Which side of the uterus is the mass? How is the mobility, like whether it is truly mobile or it is restricted mobility? Restricted mobility because of the size, or because it is you're feeling because of the advanced disease. Suppose there is something advanced ovarian CA, it will also be either restricted mobility or a fixed mass. So you have to mention that. Then after that, you have to look at the pouch of Douglas nodule, Purine nodule that we say. So whether you are feeling any of that thing or not. And the same thing, the Purine nodule, you also mentioned when you're doing a PR examination. So what Dr. Neha said, you can do a PV and a PR examination separately, or you can do a PVR in the same go. So we don't write digital rectal examination in our gynec examination thing. We write either PV and PR, or you write a PVR. And in that we don't write, so again we don't write that much elaborate. Like you just show me the PR examination that you have written, the next slide. Yeah, so you don't write so much. I'm not sure whether you are supposed to report this in your rest of the surgical oncology exams, but in gynec exam you have to report like PV, rectal mucosa is free. Are you feeling any mass through the rectum? Is there any purine nodule appreciated? Like whatever positive things you are finding out. If the rectal mucosa is not free, either it is fixed and stretched over the mass, or it is infiltrated by the mass. So that thing you have to report. Okay. So that's it. Anything else, Dr. Nia, that I have missed?
Ma'am, your mic is
Your mic is off.
Sorry, can you hear me? Yeah. So
Yes.
your PV examination, where you've mentioned your PV, just go back to your last slide. Yeah. So like Dr. Shweta correctly mentioned, you have to start from below. Cervix and vagina is normal. You need to mention, the uterus. Why is this important? Why do you think I am stressing on you to mention what the uterus is?
Because if there's a pelvic mass, it can be a uterine mass as well.
Yes.
So we have
Yes.
to.
How will you? Does your physical examination give you an idea that this could be a uterine mass versus this could be an ovarian mass? So if it is a small ovarian mass which is separate from the uterus and is generally mobile, it will be felt separate from the mass. So when you move the cervix in a uterine mass, cervix is part of the uterus. So when you move the cervix, the motion is transmitted to the uterus. So the motion is transmitted to the mass. So that helps us in distinguishing this is more likely to be a uterine mass. Whereas if when you move the cervix, it will not move an ovarian mass. And ovarian mass can be felt separately from the uterus. You can actually feel free space between a uterine mass and an ovarian mass. This is the case when ovarian mass is small and is not fixed. Where an ovarian mass is big like this mass and has restricted mobility, many times you may not be able to feel the uterus separately from the mass. So you have to mention this in your finding. Uterus was felt, the mass was felt in these cornices with restricted mobility, and the uterus was not felt separately from the mass, which is fair enough. Okay. And in a PVR only you mentioned, that you could not feel any POD nodules, or like Dr. Shweta said, rectal mucosa is free or it is infiltrated, whether it is stretched over the mass or not. How is that going to help you? Why do you want to know all this during a PVR? That rectal mucosa is involved or not?
Ma'am, it will change the management. If the rectum is involved, then it will be a case of advanced ovarian malignancy. It becomes stage 4B, ma'am.
So, rectal mucosa involvement per se, yes. The other thing, how will it help in your planning? Does it help you surgical planning in
yes,
case you take the patient after surgery?
In that case, if the rectum, if the fat links with the rectum are lost, then in those cases we have to plan for neoadjuvant treatment.
No, that is not correct. So basically, if the mass is immobile, it may let us say it is just the rectovaginal septum is involved. It is densely stuck to the rectum, but it has not infiltrated the rectum. So that doesn't make it stage 4. Okay. So even if the mass, we'll come to the imaging later, if the disease is not advanced, okay, just the involvement of rectum without the involvement of mucosa is actually stage 2. So stage 2 does not come in advanced ovarian cancer. Stage 2 is pretty much a part of early ovarian cancers. It will help you in your surgical planning in the sense that you will corroborate your clinical findings with the findings of the imaging, and such a patient may likely need an anterior resection, and such has to be communicated to the patient before you take her up for surgery. Because obviously anterior resection, depending upon how low you are going, you will have to explain the risk of stoma. Okay. So it helps in your surgical planning.
Posterior resection. I think Dr. Neha wanted to say posterior.
Resection of the rectum. AR. So, okay. That's it. Okay. Now, what is your summary?
Ma'am,
so breast and systemic need to come before your per abdomen examination. Sure. Yeah, all right.
So, ma'am, considering the age of the
examination, what is your differential? Fine. This your summary is okay. So, based on your history and finding, what is your diagnosis?
So, ma'am, considering the age of the patient and the presence of an abdominopelvic mass whose lower border is not palpable, I would like to consider an adnexal mass, which is most likely malignant. So, most likely I would like to keep a DD of an ovarian malignancy. Diagnosis of ovarian malignancy.
What are your differentials?
Ma'am, for differentials, in this particular case, ma'am, I have ruled out other causes of it cannot be a uterine mass because it can.
You have not mentioned anything about the uterus.
Sorry, ma'am.
Yeah, why it cannot be a uterine mass is what I'm asking.
Ma'am, because the patient does not give any history of fever or any history of sustained pain for a long duration. The history of pain is also short. It is around 10 days, which is also dull aching. So if it were a pyometra or a hydrometra leading to a uterine mass, she would have had history of fever and a long duration of pain. And apart from that, uh, she would have presented a bit early also. Ovarian malignancies, she has non-specific symptoms. So that is why I would like to see.
Scientific exercise, yes, the first differential will be an ovarian malignancy. But when you are talking about uterine masses, we're not just talking about hydrometra and biometra. We're also potentially talking about malignant uterine masses. The history is 3 weeks, but the patient may be feeling this history later on.
And ma'am, it can be a uterine
Causal bleeding, you mentioned this. Discharge, hematometra, pyometra, this is slightly lower down in our list. Okay. So, yes, you have to mention that as a potential this thing that you're thinking of benign causes as well when you're talking about uterus. But there is no history of any postmenopausal bleeding. So, your uterine mass, you're not suspecting a mass which is involving the endometrium, which is involving a part of the myometrium, which may present with postmenopausal bleeding, which may present with discharge per vaginum. Okay. Otherwise, they can also present with the intermittent pain and the abdominal lump which you're talking about. But again, in your examination, you have not mentioned anything about the uterus. Say the uterus was not clinically separate from the ovarian mass. You would still need to keep a differential of uterine mass below your diagnosis of ovarian malignancy and say that I would like to confirm by doing further imaging and further tests. Okay, so you cannot just go with one diagnosis and not have differentials. You need to keep 1 or 2 differentials. Okay, so you need to keep that in mind. This patient does not present with any fever, weight loss. So yes, abdominal TB is not in our list. But considering that you have not mentioned anything about the uterus, although this lady does not present with any postmenopausal bleeding or any discharge, you would still like to rule out a uterine mass. Okay. So what type of uterine masses can present with adnexal masses? Sorry, which type of, I'm so sorry, it's the other way around. Which type of ovarian masses can present with a uterine pathology, coexisting uterine pathology?
Ma'am, granulosa cell tumors of the ovary.
Yeah,
they can. The patient may present with pervaginal bleeding and precocious puberty.
Precocious puberty. अभी हम precocious puberty की बात थोड़ा कर रहे हैं. We are talking of this case, 66-year-old. A 66-year-old, you're not talking about precocious puberty. So yes. So in this case, yes, an ovarian mass like a granulosa cell tumor can present with a coexisting endometrial cancer of the uterus as well and can present with postmenopausal bleeding. If, say, this was not the case, this was a relatively younger woman in her 40s, is there a possibility of a synchronous ovarian and uterine mass?
Yes, ma'am. It can be it can be associated with Lynch syndrome.
With sorry,
ma'am, in Lynch syndrome there may be associated endometrial and ovarian.
So I'm talking about synchronous ovarian and uterine cancers. Which histopathology presents with synchronous ovarian and endometrial malignancy?
Endometrioid type of ovarian.
Endometrioid, right. And in young women, sometimes they can be associated, the incidence of synchronous can be as high as 20%. So, although not in this case, these are generally younger women where the synchronous ovarian and endometrioid cancers can coexist together. Okay, so you need to, yeah. Dr. Shweta and Dr. Anadi, any other questions, please?
So one suggestion is when you mention about the differential diagnosis, you don't have to justify the differential till the time you are told to do so. You just mention what your differential. My first differential is ovarian mass, probably malignant. Second, again, it may be ovarian mass, it may be uterine mass. That is up to you. Ovarian mass, benign. Third is a uterine mass, which may be malignant, like that. And whatever differentials, how many of them you are having in your mind, you just mention those. Then your examiner may ask why your first differential is your first differential, and then you can say, okay, so given the age, given the scenario, and that you are not able to palpate the uterus and that the patient didn't have any bleeding symptoms, so you think that she is likely to have ovarian tumor first, and given her age and the short time of presentation, it is likely to be malignant. It is when you are asked, then you will say this. Don't justify it the first way. As I said, the more you talk, the more you give the examiner to question, and you're likely to just mention something which may be wrong, and then you are unnecessarily caught. Remember this always in the exam, okay? So this is about your differentials are correct, and whatever discussion has happened, I am agreeing to that. I don't think anything I need to add further here. Another can add.
I think go ahead. Vartika, you can go ahead. No.
Okay then. So how will you manage this patient now? You have the history, you have the physical examination, the differentials in your mind. How will you manage this patient further?
Ma'am, I would first like to do an ultrasound of the abdomen, which is an extension of the clinical examination to find out the organ of origin, and it can also assess in evaluation of presence of any free fluid in the abdomen or any lymphadenopathy. And apart from that, depending upon the ultrasound findings, I can plan to go for further management. So I would like to do a CECT of the abdomen, pelvis and chest in this particular case.
So, Vartika, just a minute. Basically, as Dr. Shweta is telling you repeatedly, that don't explain everything. If you are asked what investigation you want to go ahead, just tell the investigation and let the examiner ask what specific part of the question he want to discuss actually. Okay.
Yes, sir. So I'd like to do an ultrasound of the abdomen, followed by a CECT of the abdomen, pelvis and chest.
But if you are following it just with CCT after the ultrasound, why not just do ultrasound at the upfront, given the scenario that the patient is in? Why do you want to do ultrasound first in this case?
Ma'am,
what do you do when such a patient comes to you in a clinic, 66-year lady with abdominal pelvic mass of short duration? Do you advise her to come with the ultrasound first?
No, ma'am. In our practice, we do CECT of the abdomen.
In your practice, in general practice, people will do CECT first in this scenario. There are scenarios where you will advise for ultrasound first, but I don't think given this setting that the patient presented to you, you are going to ask for ultrasound in case you have facility of CT. The thing is, you should have the facility of CT. Okay. And is it only at the imaging that you are going to stop, or you are going to ask for something?
I would like to do tumor markers. I would like to do a CA125 and serum CEA and CA99.
Yes, so these three markers generally we do. So how much is the addition of these in the final management is yet a query, but a standard of care we are doing all these three markers in any cases where we are suspecting a malignant masses which are more than 40. In less than 40, we are doing something more also, that also you should know and you should never forget. What are those?
Yes, ma'am. There are other markers like HE4 and then there's OVA1 and OVA2.
No, I'm not asking for that. I'm saying that if the lady is more than 40 years, you are asking for these three markers for sure, as a part of your workup for the adnexal mass. But if the lady is less than 40 years, then
we'll rule out markers for germ cell tumor like alpha-protein, beta-HCA and serum LPA.
Yes.
Your DMPs are giving you the answers in the chat box as well.
Yeah.
So
too much hints you are getting on this.
So I think that needs to stop. Anyways, that's what. So I agree with Dr. Shweta. So if such a patient, so she's a 66-year-old, on the basis of history and physical examination, you strongly suspect an ovarian cancer. So I don't think an ultrasound would be of much value to this patient. Why? Why am I saying that, an ultrasound will not be of much value? Can you tell me why, Vartika? In this case, why would an ultrasound not be of much value?
Ma'am, because
why is Dr. Shweta telling you that, we would like to go for a CT scan straight away? Why is that?
Ma'am, it seems to be a case of early ovarian malignancy, wherein I would like to go for a surgical staging to find out the final stage of the patient. So an ultrasound is not going to change our management in any way, or ultrasound would
Exactly.
have.
So an ultrasound will not change the management. Clinically, this looks like to be an ovarian CA because you have not found any ascites on your clinical examination. This could potentially be a surgical candidate. An ultrasound does not change our management. We would still need to do a CT scan of the whole abdomen, a CT scan with an IV and an oral contrast. Secondly, an ultrasound has very limited sensitivity in telling you about upper abdominal disease and about the regional lymphadenopathy, which will help you in deciding whether this patient comes up for the surgery or not. So your decision for surgery is based on your clinical examination, on the basis of what you have found, what is the performance status of the patient, as well as your imaging. So ultrasound tells us neither of that. Neither it tells us about the upper abdominal disease nor lymphadenopathy with accurate sensitivity unless there is gross disease in the upper abdomen or there is gross lymphadenopathy. So it will not change our management. We would still need a CT scan, and CT scan has a very high sensitivity of almost 70% in diagnosing lymphadenopathy as well as the upper abdominal disease, and this is key to basically understanding whether this patient comes up for surgery or not. Secondly, I would advise when you tell, what investigations you're going to do, start with your basic blood work first. I would like to do some basic blood investigations for this patient. These basic blood investigations like, PVC, sugar, KFT, LFT, PTINR. The reason why I'm saying this is because it is important to know the HP and the serum albumin levels as part of general assessment of what the patient is doing. Secondly, if we are planning to operate this patient, obviously we would need all this. And of course, the tumor markers, CA125, CEA, and CA19.9. And below 40, we include AFP, beta HCG, and LDH. We do not routinely do. Would doing an HE4 in this patient help you in any way?
No, ma'am.
So where is HE4
Ma'am,
useful?
HE4 is useful in patients who have a pelvic mass but a normal CA125 or a CA125 which is in the lower range. So doing an HE4 will help us to it increases the sensitivity of the test.
But now you have put the examiner in a different tangent now. So what is the sensitivity of CA125 overall and in early cancers?
Ma'am, in early cancers, the sensitivity is low. It is around 50%. And whereas in advanced ovarian malignancies, the sensitivity is high. It is about 75 to 80%.
80%, correct. So in this case where we already know that there is a big mass, she is a 66-year-old lady who has a big mass. Even if CA125 comes out to be normal, it does not change our management. This patient needs to come up for surgery provided her general condition is okay and the imaging is reassuring. Okay. So it does not change our management in any way. HE4, which is a sensitive of women who are young, who are presenting with complex adnexal masses, and where you need to rule out other differentials. So my second question to you is, you have said that CA125 has a limited sensitivity. So are there any other conditions where CA125 is known to rise?
Yes, ma'am. In benign cases such as fibroid of the uterus, endometriosis, it may be raised, ma'am.
So it would be better if you divide the causes into gynecological and non-gynecological. Gynecological include benign causes like
benign causes
like endometriosis, PID, uterine fibroids, adenomyosis, some benign ovarian neoplasms. And non-gynecological, what are the non-gynecological causes of raised CA125?
Appendiceal neoplasms.
Don't come immediately to appendiceal neoplasm. Do you expect CA125 to rise in appendiceal neoplasm?
Peritoneal malignancy.
Any peritoneal inflammation can lead to a rise of CA125. So, yes, what else? So, what are the causes? Any peritoneal inflammation due to, what is the common cause? We have just discussed it. What are the common differentials in India?
Tuberculosis, ma'am.
Correct. So, tuberculosis. So even in your clinical practice, you will see many patients who come with ascites, who come with an adnexal mass. Question to you. The patient comes with ascites and an adnexal mass. Besides ovarian malignancy, what are your other differential?
Ascites and ovarian. It can be a tubo-ovarian mass, ma'am.
Yes, in abdominopelvic mass, correct? What else?
It can be endometrioma.
Why would an endometrioma cause ascites?
Ma'am, as a part of inflammatory process.
No, it does not. No, it does not.
Unless it ruptures.
What else? A relatively rarer diagnosis. Adnexal mass ascites.
Ma'am,
your fellow mates are giving you the answer below. I think this you need to stop. Yeah. So let her answer. Correct.
Meek syndrome.
Right. Meek syndrome. So what is Meek syndrome?
Ma'am, it is a triad of abdominal ascites with adnexal mass with pleural effusion.
So which adnexal mass? Which histology is known to cause
Fibroma.
Fibroma, correct. So now coming to our point. So HE4 is useful in patients where we are where we need a differential diagnosis. Okay, where we are not so sure whether this is we are dealing with an ovarian malignancy or not. So if it was a young woman who presents with a complex adnexal mass, okay, on say an ultrasound. So this is the subtype of woman where actually instead of CT, an MRI is useful. A contrast enhanced MRI is useful. So if it was a younger woman who presented with a complex adnexal mass on an ultrasound imaging, there instead of a CT, a contrast enhanced MRI is more useful because it will tell us, it will help us in distinguishing whether this mass is actually malignant versus something which is benign like an endometrioma. Along with that, so CA-125 can rise in gynecological conditions like endometriosis. It is where here that HE4 is more useful because generally HE4 is more specific. It does not rise in endometriomas as compared to ovarian malignancy. So where we, in a young woman, where we want to distinguish between a potentially malignant ovarian mass versus an endometrioma, okay, there it is advisable along with a contrast enhanced MRI and a CA-125 which has already been done to include HE4. So if HE4 is normal and your MRI findings are reassuring and suggestive of an endometrioma, if this endometrioma is small, okay, these patients can be kept on conservative management instead of subjecting them to surgery. So HE4 is more useful in those cases. You understand?
Yes.
So now if you're talking about ovarian cancer, about these tumor markers, what is RMI?
Ma'am, risk of malignancy index. It is an index which includes the postmenopausal status, the age of the patient, and CA-125. On that basis, we can assess the risk for ovarian malignancy.
So what ultrasound features are distinguishing between a benign versus a malignant mass?
No. Come again. What did you say about RMI? What did you say about RMI?
Ma'am, it includes the postmenopausal status, the age of the patient, and CA-125.
So it's
No, not the age. It's the ultrasound score.
Yes.
Yeah, you're right. I didn't pick that up. Yeah, it's an ultrasound score.
It's premenopausal, postmenopausal, 1 and 3. Then ultrasound scores, either it is there are 5 ultrasound features, and depending on that you score. Then the third is the CA-125 absolute value, and it is a product of the 3. Yeah? So what is the cutoff that you take for RMI? So one suggestion for this thing that HE4 we discussed. I am not sure Dr. Neha can comment on this better, but I feel that keep this HE4 thing for your theory paper.
Yes, correct. This is not to be mentioned in your practice.
Don't mention
not
it in
at all.
your practice because we are not using it right now as of now as a standard of care.
Correct,
we are not using it to triage any of our patients, at least in our setting.
Yes, so only if you are asked about it. Yes.
The moment you mention this, you are just taken to other direction.
Absolutely. You go in a different direction.
Yes.
So what are the ultrasound features which distinguish benign versus malignant?
Ma'am, if it is a complex ovarian cyst with multiple septations or any solid component, if there is presence of a thickened capsule and
Is it a thickened
apart
capsule or a thickened something else?
thickened thickened capsule and thickened septations
Septation. Septation is more important. So, a unilocular clear cyst is more likely to be benign, whereas a multiloculated cyst with a thickened septae with solid component with what else? Any other features?
ma'am, size of more than 5 centimeters.
RMI में the size factor doesn't come.
It
At least in
doesn't come
RMI.
in.
There are
Size is
different
not
types
there.
of scores, yeah. There are different types of scores, but in RMI, the ultrasound score doesn't incorporate the size. It is unilaterality versus bilaterality. It is unilocular versus multilocular. Thick septa versus no septa or very thin septa. I think the septa size cutoff is 3 mm.
3 millimeters, yes.
3
Correct.
mm. And then presence of ascites and presence of obvious myths. So these are the 5 points that you take in
Correct.
ultrasound. And RMI you should know because you are likely to get a short notes also in your theory paper. That's an important thing. Okay, so you should know including the cutoff also. Because quite a number of places will use it, especially those places which are not which are not truly oncological setups. No, those people will use it because what is the importance of RMI? That is used to triage masses, evaluate suspicious adnexal masses to categorize into low risk versus high risk. Okay, so if it is high risk, generally they say that it should better be treated at a center dealing with oncological background. So better for a oncosurgeon, whether it is surgical oncology or gynecological oncology. And if it is less, means mass is less likely to be malignant, and then even a obstetrics gynecology, like what we call as general gynecology team, can manage it at a setup which is not very much equipped with oncological background also. That is the main rationale of RMI. Okay, so that you should know. That's a practical thing, and that can be asked as a notes also.
Okay. So, you've done your investigations, your blood work, including including your tumor markers. You've done a CT scan. So, any other modality, any other investigative modality which is used sometimes in diagnosis of these conditions in management? Okay.
Ma'am,
Any role of
MRI.
endoscopies? No, MRI is something else.
Ma'am,
Any role of endoscopies here in this case? Do you do them
ma'am,
routinely or do you do them in specific cases?
only in specific cases, ma'am. Like
So which
if
cases
there's
would
a
you like to do an endoscopy?
ma'am, if the patient has GI symptoms or if it is a case of mucinous neoplasm.
So you would not, although there are some features of mucinous neoplasm on CT, you may not know it beforehand whether you are dealing with mucinous or not. So one is presence of GI symptoms. Yes. What is the other this thing?
Ma'am, if
So why are we doing CA and CA 19.9?
To rule out colonic origin and hepatobiliary origin of the tumor.
Yes. So where? So now
So
coming to that.
if patient
Yeah.
Ma'am,
Patient has.
if a patient has familial
Is there something called CA 125 CEA ratio?
yes, ma'am. If CA 125 CEA ratio is more than 25, then it indicates an ovarian malignancies. If it is less than 25, it indicates more towards a GI malignancy.
Correct. So A, then the patient has certain GI symptoms. B, where your CA and your CA 19.9, CA is mandatory. CA 19.9 many centers are doing. We in Tata were routinely doing CA 19.9 as well. But either which ways, if either of these two markers are elevated or CA 125 by CEA ratio is less than 25, or there is an atypical presentation. For instance, there are bilateral ovarian masses with intraparenchymal liver mets. Example, I'm giving you an example. These are the cases where we consider upper GI and lower GI endoscopy. Okay. So what is the role of MRI and what is the role of PET-CT? Tell me.
Ma'am, MRI is used to better characterize a lesion, an ovarian lesion. So, in patients with early ovarian malignancies, where we have to characterize the lesion, then in those cases, an MRI can be used. And
So
and
I
PET
think
CT.
what I told you before, so MRI, so what type of an MRI do we do? Which type of MRI? Is it a non-contrast MRI or a contrast enhanced MRI?
Contrast enhanced MRI.
Correct. So in a patient like this who is presenting with a 25 centimeter post-menopausal lady, will an MRI help you over and above a CT scan?
No, ma'am, not in this particular
So
case.
in which subgroup of patients would an MRI be helpful? I have given you the answer just a few minutes back.
So, ma'am, if the patient has an adnexal, small adnexal mass, and we have to characterize it,
Why do we need to characterize it? In case if we are already doing a surgery, if it is not going to change our management, where we'll do an intra-op frozen section, how does characterization of the mass before surgery help you?
ma'am, ma'am, if it is a benign lesion, then we do not need to operate. We can straight away.
Correct. So in which subgroup of patients would an MRI help them? If in this case, would doing an MRI help you? Will it change your management?
No, ma'am. We have to stage the patient anyways. But
Yes.
in small ovarian tumors, small ovarian tumors or ovarian cysts, where the chances of benign tumor are high, then in those
Yeah,
cases.
so it has got nothing to do with the size. It has got to do with the age of the patient. If it's a younger age group patient, okay, where a patient is presenting with a complex adnexal or an ovarian cyst on a pre-op imaging, like on an imaging like an ultrasound, it is there that we need to characterize the tumor, okay. So like I said, in cases of young women who present with endometriomas, these also present with a complex mass with solid component. And if you do a CT in these patients, the CT may also show a complex mass with a solid component. But an MRI, a contrast enhanced MRI along with the tumor markers will help you distinguish whether we are dealing with an endometrioma or we are dealing with a malignant mass. Okay. Because not all endometriomas require removal. We remove benign ovarian masses. What is the cutoff for benign ovarian cyst in a premenopausal woman for surgery?
Ma'am, the size?
There is a size cutoff.
Ma'am, 5 centimeters.
It's 8 centimeters. Okay. 6 to 8 centimeters. So generally an endometrioma which is small in size does not require removal unless it is the size is one criteria. The other criteria is where the woman is infertile. So you don't need to go into that. But generally, suffice it is to say, if it's a small endometrioma, it can be managed medically. Okay, and a patient may not be subjected to unnecessary surgery. So it is in this subgroup of patients where we need to characterize the mass. Where it is already a big mass, where in any case you would be subjecting patient to a surgery and doing an intra-op frozen section. There it is not necessary to characterize the mass. Okay, where it changes your management, where it is important for you to know beforehand whether I'm dealing with a benign or a malignant mass. There it is important to do an MRI. Okay. So what is the role of PET CT?
PET CT, ma'am, it is to be done in advanced cases, wherein we are planning to go for neoadjuvant treatment and or we are suspecting distant metastasis.
So does a PET CT give you much more information than a contrast enhanced CT of the thorax, abdomen and pelvis? So in many cases, so we know that, most of the ovarian cancers present in advanced stages and most of the centers in India may not have a PET CT. So is it necessary for them to refer to a center of PET CT where PET CT is available for you to decide whether the patient goes for upfront surgery or goes for neoadjuvant chemo?
I think she's out of network, Dr.
Vartika, are you there?
Is she here?
I think
No,
she
no.
got disconnected.
Then
But
we got
otherwise,
disconnected.
someone else can answer.
Yeah, anybody else can answer.
Madhuri, Sudhakaran. Would you like to take the question?
Yes, ma'am. Good morning. Ma'am, no, ma'am. We can go ahead just with the CCT abdo pelvis with the thorax. PET-CT is not mandatory.
Yes.
Correct. So the PET-CT is not routine recommendation either in early or in advanced ovarian cancers. Because a good contrast-enhanced CT abdomen and pelvis will give you more or less the same information which a PET-CT, and sometimes better information, because the slices in contrast-enhanced CT are much thinner than the slices which we use in PET-CT. Secondly, there are many false positives in a PET-CT. And you can have, lymphadenopathy or any other disease of infective pathology also lighting up on a PET-CT. So where you're already doing a CT of the abdomen and pelvis, plus minus a CT thorax, okay? CT thorax is generally recommended in advanced ovarian cancers, or especially in patients which are presenting with a supraclav lymphadenopathy, to rule out any mediastinal pathology. So it does not add to our management, okay? So, this is basically it. So, anything else, Dr. Shweta and Dr. Anadi?
PET-CT has a role in evaluation of the recurrent disease also, madam.
Yes. So you are talking about the upstream setting right now.
Not in this case. It has a role in recurrent in those cases where you are planning to do a secondary cytoreduction, where you are, you are thinking of a patient has a long disease-free interval, where the patient has an oligometastatic disease. There, such patients could be potentially coming up for a secondary cytoreduction. There, yes, PET-CT definitely has a role. But upfront, no, I would not.
So what they guys back with regarding PET-CT again, I will tell you. We used to do PET-CT in cases of recurrent ovarian cancers when we were planning secondary cytoreductions. As of now, the standards, if we are having a good CT thorax abdomen pelvis in a recurrent setting again, which is giving you the information that you need for surgery. Again, you can do away with PET-CT even in those cases.
I agree, Shweta. Yes, I agree. But for theoretical, this thing, I think that's the only role.
Yes,
but I completely agree with you. Yes.
Yeah, because NCCN has said everywhere in the recurrent setting, PET ka role hai. So, we have to respect it somewhere, and therefore we still continue to say recurrent setting hai. But if you are having good CT thorax abdomen pelvis,
I agree. I agree, but yes, for academic purpose, in ovary, that's the only role.
What in my experience that sometimes we go for PET-CT even in upfront setting that has come with experience, not read anywhere, is when there is suspicion of bony mets in upfront setting. Occasionally you will find such cases, bony mets. Then the radiologist will say, okay, PET-CT gives you a better thing about everything. Along with the disease extent, intra-abdominal, other things, along with that, you will get the bony lesions also. So that is one place where they will say, okay, get a PET-CT, then that will give information about all things. And second is sometimes unknown primary. You are not getting a clue as to where this disease has come from. You are getting some carcinoma, some poorly differentiated carcinoma. You don't know from where it has come, whether it is ovarian, whether it is coming from somewhere else. But these are adnexal mass and some peritoneal. In these two settings, even upfront setting, you may ask for a PET-CT. Otherwise, by and large.
So for your case, Vartika, for now, like recommendations is CT is enough. Though the centers where the PET-CT is available, they can ask for it, but the standard recommendation is the CT thorax abdomen pelvis. That is enough.
For you, the academic the role of PET-CT is in a recurrent setting, not so much in an upfront setting. Okay. So in this case, with this history, do you have any imaging model? Do you have any reports of this patient on your slide?
The patient has not been evaluated yet.
Okay. So then I'll give you a case scenario. Say her CA125 was 600 and her CT showed 25 into 20 centimeter abdominopelvic mass, possibly arising from ovary with loss of fat planes with the rectum. The upper abdomen shows omental thickening. Okay. There is minimal ascites and there is no lymphadenopathy. So how will you manage this patient?
Ma'am, I would like to plan the patient for surgical staging after looking for adequate physical fitness for surgery, after going for a pre-anesthetic checkup. Then I would like to plan for a surgery. I would like to do a staging laparoscopy followed by not a staging laparoscopy. I would like directly like to go for surgical staging. I'd like to open the abdomen from ziphus sternum to the pubis, and then after excision of the mass, I would because of the size of the mass, after excision of the mass, I would like to inspect the peritoneal cavity to look for to stage adequately stage, and if there are any obvious deposits, I would like to excise it, and if it is resectable, I would go for TAH PSO, and we can plan for a rectal resection, LAR also, and if the fat planes with the rectum are not maintained.
What is your opinion
I-
regarding biopsy?
You need to answer, what is the name of the surgery? What is it called?
Ma'am, surgical staging for ovarian cancer.
Staging laparotomy for ovarian cancer.
Staging
Yeah.
laparotomy.
So what are the components of a staging laparotomy?
Ma'am, it includes total abdominal.
Just go serially. Now you go serially. Okay. So you make an incision, you palpate, you remove. Now I've given you the hints. Now go in that order.
Ma'am, I would do a total abdominal hysterectomy with bilateral.
No, you start with your incision, then you inspect. Yeah. Okay. Fine. Fair enough. You want to remove the mass first.
Yes,
But
ma'am.
yeah, and then what do you do? Okay, let us say you've removed the mass first because you are not able to see the rest of the abdominopelvic cavity. So what are the components? Let us say the mass was small in size, or in this case you've removed the mass and you see everything before you. What do you do? What are the components of a staging laparotomy?
Ma'am, adequate inspection of the of all the quadrants of the paracolic gutter, the pelvis, the subdiaphragmatic area, and followed by if there is limited resectable disease, then we can go ahead with TAH PSO and bilateral pelvic lymph node dissection.
So, Vartika, is there any role of some cytology, some collection?
Yes, sir. We'll do a peritoneal cytology as
So,
well.
definitely you should do that thing before the THBS.
Before you remove the mass. Okay, so how do you take cytology?
Ma'am, if there is evident ascites, then we will take that for cytology, or we'll infuse 50 ml of saline, and with lavage, we will after lavaging, we'll send it for cytology.
So do you only do 50 to 100 ml of peritoneal washings from the pelvis and send it?
Ma'am, also in the paracolic gutters.
Theoretically, how do you take cytology in case of a staging laparotomy? You have said that you will inspect all areas. So by all areas, you mean the pelvis, okay? Pelvis, you mean the bladder, you mean the POD fossa. You go in a clockwise fashion, okay? You start from the appendix, go along the paracolic gutters and the ascending colon. Then you reach up to the right undersurface of the diaphragm, inspect and palpate the liver. Then the omentum, the transverse colon, the stomach, then come to the left hypochondrium, palpate the spleen, the left undersurface of the diaphragm, the left paracolic gutters, the descending colon, the rectum, and then come back to the pelvis. So this is inspection and palpation. Then when you take a cytology, how do you take a cytology? I've given you the hint. How do you take a cytology?
Ma'am, we infuse around 200 to 300 ml of saline.
You don't increase the saline. You just take it from different quadrants. Okay, it is not just the pelvis. If you are instilling 100 ml of normal saline to take cytology, it is not just from the pelvis. You have to take it from every part of this, from the pelvis, from the paracolic gutters, from the undersurfaces of the diaphragm, or you use a scrape cytology for the undersurface of the diaphragm, either using a tongue depressor, or you take a red rubber catheter, put it along the surface of the liver, under the right undersurface of the diaphragm, instill saline and then aspirate it. Okay. So the cytology 50 to 100 ml has to be taken from each of these segments, not just from the pelvis. Routinely, yes, we are in a hurry during our practically and we do not do it as religiously as it has been mentioned. But you need to mention what is there in the books, what is actually the right way. Okay. Okay, so then what else? What else will you do after this?
Then we'll do lymph nodal. We'll do
you have just inspected, palpated. and you've taken the cytology. Abhi se bitna hua, you've done only this. Now what will you do?
Ma'am, if there is a resectable limited peritoneal disease, then I would like to go ahead with complete surgical staging. Otherwise, if
Yeah, so what are the components? Kya karoge? What will you do? It is resectable. It is early stage. Okay. It is early. It has not spread anywhere. What will you do after after inspecting, palpating, taking cytologies from multiple quadrants, including under surfaces of the diaphragm? What will you do next?
ma'am,
So Vartika, you should be like telling 1, 2, 3, 4. These are the steps for the surgical staging of ovarian cancer.
yes, sir.
Okay, so it should be like all the steps you should mention.
Yes, sir. So we'll do a TAH PSO with pelvic lymph node, bilateral pelvic lymph node dissection with para-aortic lymph node dissection with the total omentectomy, and random peritoneal biopsies may be taken if there are no evident peritoneal deposits. And
so what all are the sites from where you want to take the peritoneal biopsies?
So from the pelvis, from the right and left paracolic gutter, from right subdiaphragmatic area, and
where all from the pelvis? Is it? Do you do a total peritonectomy, total pelvic peritonectomy in an early case, or you take biopsies from different areas of the pelvis?
Random.
Pelvis has different components, so where all from the pelvis?
Ma'am, we do random biopsies.
No, so it is right pelvic peritoneum, left pelvic peritoneum, the bladder fossa, the POD fossa, and sometimes even the ovarian fossa. These are at least the components of a pelvic peritoneal, multiple pelvic peritoneal biopsies. Right paracolic gutter, left paracolic gutter, okay? And obviously the diaphragm, if you've taken cytology, some people like to take the biopsies as well, okay? So do you necessarily need to do a total omentectomy in an early case?
Ma'am, we can.
Not yes, we can. What should you do?
Ma'am, we have to do, it is better to go for a total omentectomy because it has been seen that if complete staging is done, it upstages the malignancy up to 30% of the cases.
No, that is not true. By staging, what we say, staging is okay, now let me come to these terms. What is the difference between staging laparotomy for ovarian cancer versus the cytoreduction? Cytoreduction, what is the difference?
Ma'am, in staging laparotomy, we are doing a surgical staging for the early ovarian malignancies. Whereas, so in those cases, we have to do a complete lymph nodal dissection as well. Whereas in cytoreduction, we are only removing gross disease. We are doing a debulking so as to achieve an R0 resection. And for lymph nodes also, we are going to...
forget about the lymph nodes. Lymph nodes is, just keep the lymph nodes aside. Staging laparotomy is a term described for early ovarian cancers. Early ovarian cancer is stage 1 and stage 2. Cytoreductive surgery, whether you do it upfront, which is called as primary cytoreduction, or you do it after 3 cycles of chemo, which is interval cytoreduction, is a term which is described for advanced ovarian cancers, okay, where the disease has already spread beyond the confines of pelvis, okay. Now you forget about the lymph nodes. Now, in a staging laparotomy, which is being done for an early ovarian cancer, forget about what you do. Forget about what is being done. Tell us what is right. In a staging laparotomy, where you have an ovarian mass, the disease has not spread anywhere. It seems to be an early ovarian cancer. Does necessarily doing a total omentectomy increase your chances of survival in an early stage ovarian cancer? No. So the purpose of staging, whether you do it in ovarian cancer or you do in endometrial cancer, is to stage the disease. By staging the disease, we mean we are trying to find disease outside the confines of the ovary so as to allocate a proper stage to the disease. That is the whole purpose of doing a pelvic and a para-aortic lymph node dissection, a systematic lymphadenectomy in an early ovarian cancer, because it upstages the patients in up to 20 to 25% cases. So the early ovarian cancers can be upstaged in up to 20% cases where we do a lymph node dissection because of the involvement of pelvic or para-aortic lymph nodes. Okay. Similarly, the role of doing an omentectomy is to find potentially microscopic disease in the omentum. Okay. So as part of staging laparotomy, what has been described in all your books and what you should say without putting your foot in the mouth is an infracolic omentectomy. Total omentectomy is generally what we do in a case of advanced ovarian cancer, where we are taking advanced ovarian diseases. What we do practically, yes, I may be taking more than an intracolic omentum practically. But for your exams, part of staging laparoscopy is TH, BSO, bilateral pelvic and para-aortic lymph node dissection, and intracolic omentectomy, multiple peritoneal biopsies, and in case there are adhesions, like in this case, we knew that, there is some amount of adhesion with the rectum. So this patient may or may not require anterior resection of the rectum. But even if she doesn't, you should be taking biopsies from the adhesion, because those adhesions may also harbor microscopic disease. So the idea behind a staging laparotomy is to find whether the disease has spread beyond the confines of omentum in terms of microscopic disease. That is why we're taking cytology. That is why we're doing systematic lymph node dissection and an omentectomy. Where the disease is already advanced, we don't normally take cytology because there is no role. We already know, we can already see deposits in the abdomen, in the peritoneum, in the omentum. Okay. So you should know this. This should be, you should remember this staging laparotomy. There is no this thing. Okay. So let us say, in this case, 66-year-old lady, the CT, besides the presence of an adnexocytis, peritoneal deposits, and
Ma'am, your voice was not audible. Can you repeat?
In this case, the similar age group, 66-year-old, if the CT showed an adnexal mass, presence of ascites, peritoneal disease, and the omental deposits, okay, how will you proceed with the management of the patient?
Just before going to the advanced disease, Dr. Shweta, there are a few questions regarding the role of the frozen section and staging laparoscopy. So, would you like to discuss something about that?
So actually the thing has moved quite ahead. So going back to frozen section, what I will say is the first question which I wanted to ask at the upfront. Given the findings that you had adnexal mass and omental thickening and some ascites with a CA125 of 600, what do you think about preoperative biopsy? And then we can talk about frozen section.
Ma'am, preoperative biopsy may be taken if if the patient seems to be inoperable, if there is advanced disease, or if the performance status of the patient is poor, so that we cannot go for a surgery. So in those cases, to prove the diagnosis, we can take a biopsy.
So I agree. What you are saying is was the conventional thought, but as of now, any patient whom you are thinking that the disease will be, what is the reason that you don't take a pre-op biopsy? I will just make the matters concise because then we are taking
out of time.
Okay. So I will just tell you in brief what is the rationale about it. Okay. So preoperative biopsy we generally don't take because there is a fear of upstaging. So what do you upstage it from? So suppose a tumor is 1A, preoperative biopsy will make it 1C. In case in the CT scan you are seeing evident disease which is more than 1C, that is you are seeing omental caking, you are seeing ascites. In that case, there is no harm in taking a preoperative biopsy in case we are planning something like a cytoreductive surgery also. And that is what is practiced right now in most of the institutes. I totally agree with you that some people will still reserve it for only those cases who are going for NCT. But as an institutional protocol where I have worked and quite a few that I know of, most of the people will do a preoperative biopsy to confirm the diagnosis of primary ovarian tumor before planning for any cytoreductive surgery. Okay. It is because frozen section that Anati mentioned, suppose you have taken a patient and you are planning for intraoperative frozen section. Frozen section has some limitations. It will tell you about whether carcinoma is present or not, whether it is malignant or not. It is not going to tell you about the grade of the tumor. It is mostly not going to tell you about the origin of the tumor. Okay. So it has happened that you have taken a patient for some cytoreductive surgery, done the full cytoreduction only to know in the final histopathology that it has turned out to be lymphoma, it has turned out to be COX, it has turned out to be some GI primary or something from some other primary. So as a matter of caution, wherever you are planning something like a cytoreductive surgery, it is always a good idea to do a preoperative biopsy if there is no fear of upstaging it. Okay. So when there is evidently early stage tumor on CT scan, you go for frozen and proceed, you prove it malignant and go for staging. else you plan for preoperative biopsy and then you do. Pros and limitations that you have to understand. This isn't concise. I didn't want you to answer because I thought if I answer, I will make the matter short. Okay, so now we can talk about the adjuvant therapy after this, है ना?
So, Dr. Neha, as per Dr. Neha's question, in the case scenario where there is ascites along with the omental nodules.
This week, we will keep advanced ovarian cancer for a separate, because that's a topic in itself. So if you want, we can take advanced ovarian cancers, because then there are a lot of trials and there is a role of HIPEC, everything which these people will be asked. We can keep that for a separate class. So you need to go with this idea that an upfront operable ovarian cancer should not undergo a biopsy. Okay? That is very important. Please don't advocate biopsy for an upfront early operable ovarian cancer. So somebody has asked the role of staging laparoscopy. So, do you want me to tell it or will you tell it?
Yeah, please, any of you, please.
Okay. So, where do we do what is the role of a laparoscopy? So, in ovarian cancer, the role of laparoscopy is generally in those cases where we have indeterminate operability. Okay. So, say a case which is presenting with ascites, some peritoneal disease, but the performance status of the patient is good. Okay. And where you are not sure whether you will be doing taking the patient up for upfront or for neoadjuvant, where you would like to assess the disease completely intraoperatively, where the status is indeterminate on the basis of clinical imaging. Okay, there in those cases, staging laparoscopy is recommended. So you do a staging laparoscopy. If you feel you are able to achieve an optimal cytoreduction, then in those cases you go for primary cyto or interval cytoreduction, whatever the case may be in the same setting. And if not, then you close. And in cases of ovarian cancer, you can, take a biopsy if it is needed. Okay. So staging laparoscopy is not advocated in all cases. So it is generally in those patients where the operability is indeterminate. With regards to taking of biopsy, if you do require a biopsy in an advanced ovarian cancer, even if it is to start neoadjuvant chemotherapy, this is easily done by the intervention radiology by an ultrasound guided or a CT guided biopsy from a representative lesion. Okay, so you do not necessarily require laparoscopy in all cases to take biopsies and to confirm the histology, even if you were planning to take the patient up for neoadjuvant chemotherapy. So the role of staging laparoscopy is in those indeterminate advanced cases where you are deciding between primary versus interval cytoreduction. Okay, so what is adjuvant? Okay, this patient, okay, so say the final, you've done the surgery, the final stage comes out to be 1C high grade serous ovarian cancer, 1C. So what will you do? Adjuvant.
I would like to give adjuvant chemotherapy to the patient in the form of paclitaxel carboplatin based therapy. 6 cycles are preferred, and the dose of paclitaxel would be 175 milligram per meter square, and for carboplatin it will be area under the curve 5 to 6, and
frequently is this given?
3 weekly is given.
Yes. Okay. Is there another alternative regimen?
Yes, ma'am. There's dose-dense paclitaxel regimen, wherein it is given weekly, and with a lower dose of paclitaxel.
Yeah, so it's 80 milligram per meter square, and if you're combining it with weekly carboplatin, it is AUC2 every week. Anyway, so I think we can keep that for the later discussion, because dose-dense versus conventional is another topic. So, in what cases would you not give chemotherapy?
Ma'am, in
cases of ovarian cancers do not require adjuvant.
Stage 1A, 1B, low-grade malignancies, and stage 1, all stage 1A, 1B, low-grade malignancies.
Grade 1, correct, yes.
Yes, ma'am.
So all the rest you give adjuvant chemo. Grade 2 is indeterminate. Some people like to give, some do not. But yes, no chemotherapy is stage 1A, 1B, grade 1. So, which are the cases where if a woman is young, say this is 66-year-old, say a woman was 30 years old, has not completed her family, has been found to have an adnexal mass, which on frozen section turns out to be malignant, okay? And you have to decide whether to offer her fertility sparing surgery or not. And obviously, you have ruled out that the disease has spread anywhere else. So, which are the women where you can offer fertility sparing surgery?
Ma'am, in germ cell tumors,
No, I'm talking only about epithelial right now. First you tell me about epithelial, then you come to other histopathology.
ma'am, endometrioid on low grade.
First mention the stage, the grade, and then the histopathology.
Okay. Ma'am, stage 1A, limited to one ovary. If the disease is limited to one ovary, and if both the ovaries are involved, then we can do a bilateral self-oophorectomy and preserve the uterus.
But the question is very simple. Which stage, grade, histopathology? Okay, which are the women in epithelial ovarian cancers where you offer fertility sparing surgery? So the answer is stage 1A, grade 1 and 2, serous, mucinous, endometrioid. Okay, so it has to be confined to the ovary. It has to be a low grade, grade 1 to grade 2. Okay, and it has to be a serous, mucinous or endometrioid pathology. Clear cell is actually stage 1A. There is a controversy, but for you people, you consider it as a high grade cancer. So that is why clear cell, the jury is divided. We do not offer fertility sparing surgery. Okay, so I think, yeah. Shweta, any other question? Yeah, besides epithelial, which ovarian cancers, which other you were saying, besides epithelial?
Sorry, ma'am.
Besides epithelial ovarian cancers in a young woman, which type of other cancers do you offer fertility sparing surgery?
Ma'am, germ cell tumors of the ovary.
Yes. Another epithelial group is borderline ovarian cancers. Borderline ovarian cancers, you go for a fertility sparing surgery. Germ cell tumors, sex cord stromal tumors, which are early granulosa cell tumors, or even early Sertoli-Leydig tumors. These are cases where you do offer fertility sparing surgery. Okay. So I think we need to discuss borderline ovarian cancers also, Anadi. If we have time, we can discuss it now. Otherwise, let me know.
So I think it's already almost like 2 hours.
Yeah, I think इनका retention rate भी कम हो जाएगा. After some time, they will not.
I know. No, there are still. I think at
we
least
may
40.
keep a separate class for like advanced along with the borderline. So like
we can have a discussion of borderline because that's important for them. Yeah. Sure. Okay. Yeah. Okay.
Otherwise, the standard of knowledge was quite good. I was impressed.
Yeah.
Yes, and it's very hard to impress Dr. Shweta. Even I'm terrified of her.
So, good, Shweta. All the best. Oh, good. Sorry, Vartika. All the best.
Thank you.
All the best to all of you. Okay. Yeah. Bye.
Bye. Bye.